Okay, so whistle-stop tour of two phases, which were three separate studies. Yeah, so you're all familiar with the format, and Kathy has alluded to this already. I suppose my role, and Michael Dowling, the registrar in geriatric medicine, so I'm a consultant in geriatric medicine, Tala Hospital, and Michael Dowling, registrar, was to facilitate the structuring of the data collection and also then to measure the effect that ECHO was having in each of the different phases. And specifically within phase one, we sought to look at maybe more slightly softer outcomes in determining confidence levels among staff, along with the theme of ECHO, which was to build confidence in managing complex issues through spoke-spoke interaction. And then whether this effect persisted at 6 weeks, which is something that maybe hadn't been tested before, a persistent, sustained improvement in confidence. So this paper was published in the International Journal of Palliative Care 2019. So we targeted 6 nursing homes by random selection, and we felt that we could get high quality data from a smaller group of nursing homes. And for each topic, they completed a pre-lecture and a post-lecture questionnaire. And then we phoned them again 6 weeks later and asked them the same one. It was a simple question. For example, in the management of restlessness and agitation and end-stage dementia, we said, how confident are you in managing residents with dementia? How confident are you managing end-stage dementia? So a simple format. And as I say, we started with 6 nursing homes, but the key was to get high participation rather than working with trying to generate statistical inference from a data set yielding only maybe 60% of those who attended. So 83% of all those who attended, we had pre-questionnaire data, post-questionnaire data, post-lecture data, and 6 weeks post-lecture. We found that advanced care planning, if you look at the pre-lecture score from 53 people, went from about 6 up to 7.8 and persisted at 6 weeks with 40 people. So there was a 40% increase in confidence levels if this is one lecture, advanced care planning, immediately after the lecture, and that confidence was sustained 6 weeks later. We found the same for other lectures, nutrition and end of life. Indeed, when you compiled all of the lectures together, we found a very significant increase, p-value less than 0.0001, with a 40% increase in confidence among staff who had just finished the lecture, and that sustained at 6 weeks, specifically in the topics that we had focused on. We subcategorized the data, in subcategorization or post-hoc analysis of the data, we found that didn't matter whether you were a nurse or non-nurse, and it also didn't matter whether you had 15 years experience or less than 15 years experience. So everyone benefited in the enhancement of their confidence levels significantly, and that persisted at 6 weeks. In part 2, then, we were more ambitious in looking for more complex and more comprehensive data collection with focusing on more complex outcomes. And the part 2 was primarily in St. Francis Hospice, but also Our Lady's, and among 20 nursing homes, North and South Dublin. Again, 10 fortnightly sessions using the usual ECHO format. Transfers to hospital, we focused on whether transfers to hospital were reduced in an ambitious approach. We also looked at what was the evidence for changes in advanced care planning practices within the nursing homes. So 2 specific focuses. So 20 nursing homes enrolled. Many, unfortunately, didn't attend sufficient sessions. So we put an arbitrary cutoff at attending at least 4 sessions for study inclusion, which amounts to 15 nursing homes. Now, we had really comprehensive data on the 15 nursing homes, and we chased them for months, making sure that we had high quality data and a high percentage of complete data sets, which was challenging. You know, for example, even for the transfer to nursing homes, the date and time, what was the primary reason, what was the resident's primary diagnosis, who commenced the referral, and there's about another 8 or 9 questions all around that transfer. So we had a lot of good data around each individual transfer. Separately, we asked the nursing homes to comment on their resuscitation status, their expressed wishes regarding transfer in all their participants, all their residents, not just those who were transferred. So 2 separate foci. So what we found was that when we looked at the 6 months before ECHO, with 130 patients transferred, and the 6 months after the commencement of ECHO, not after the finishing of ECHO, because we figured they wouldn't fill out the forms after they'd finished ECHO. 6 months pre and 6 months post, there was no difference in the number of admissions per nursing home, and no difference in the residents staying, and no difference in the number of residents transferred. So We wondered would the GP be involved more often? That didn't make a difference. We wondered about out-of-hours doc transfers, and that didn't make a difference. We wondered about weekend admissions, and that didn't make a difference. The ECHO program, unfortunately, didn't impact on that. Pain as the primary symptom for transfer did seem to be statistically significant, highly statistically significant. But then if you look at enough metrics, you will encounter some maybe some positive findings. But it does suggest perhaps that there was less reasons for uncontrolled pain, which would have been the focus of a palliative care program. You can't control things like falls, fractures, abdominal pain, query, obstruction. You're targeting a very specific subgroup of patients that may or may not be, and that's probably the source of transfer for only a small percentage. So if you select out those for whom pain was the primary symptom transfer reason, then yes, there was an impact, albeit a small number of people were transferred primarily for pain, only 8%. But it's a small signal to potential impact. No impact on DNR orders in place in those transferred. However, there was a significant improvement in expressed wishes around emergency hospital transfer. Now, when you break this down and you look at those with express wishes around emergency hospital transfer, what we found was that there was certainly much more discussions with the patients around what they'd like, but more often than not, they said they wanted to be for transfer. Now, you could look at this in another way and say that actually, amazingly, of those pre-ECHO who were transferred to hospital, 40% of them hadn't wanted to be transferred to hospital beforehand, whereas that was much less likely to happen after ECHO. So there was more appropriate transfer to hospitals. And I believe that while the rates of transfer remain the same, I think there was a different type of person being transferred to hospital, and that resulted in maybe some statistical anomalies that we encountered. However, it did result in, it does possibly explain, what I will say though is that for transfer express wishes increased, but that people invariably state, or more often than not, stated that they wanted to be for transfer. I believe that a shorter session, 10 sessions, many of them attending 6, probably raised their awareness of the need to discuss it, but didn't inform them enough around the outcomes and the futility of potential transfer so that they couldn't affect the decision. If we look at the second form, which was all residents in all of the nursing homes that participated, 590 before ECHO, 590 after, so large data. And the red box first, we found that there was an increase in the numbers of patients who were deemed not for resuscitation. So the previous data I showed you was only among those transferred. But if you look at all of the residents in the nursing homes, then yes, we did improve the numbers of patients who are not for resuscitation. And that is, in my belief, a good outcome that will have a sustained benefit and should transfer to inappropriate transfer to hospital. However, correctly, probably, and maybe surprisingly, the discussions beyond resuscitation centered around, when they centered around end-of-life care or transfer to hospital, the residents said that they would still like to be transferred to hospital and didn't want end-of-life care, i.e. shutting off from hospital. And that, I believe, is probably appropriate also. So ECHO impacted in an increase in resuscitation decision, not for resuscitation, and an increase in discussions, albeit resulting in likelihood of transfer to hospital rather than not for transfer. So that's just a summary slide around what I've said. Didn't affect weekend transfers, but was more likely to have expressed a documented discussion about transfer. And the symptomatology around pain seemed to be less frequent. Yeah. So I'm running through this, but apologies, but there's a lot of data to cover. So as well as that, within that phase, we realized that St. Francis Hospice provide an exceptional service in the community to 8 nursing homes. And they've excellent data around the phases score and pain scores and carer stress and everything in those 8 centres. A phases score, I'm sure everyone's aware of it, run from 1 to 5, 1 being stable, 5 being deceased, 3 being deteriorating, 2 unstable. So phases score is used very frequently by the palliative care nurses who go out to the nursing homes around St. Francis Hospice. So we identified 8 nursing homes around St. Francis Hospice that had attended at least 4 ECHO sessions, and we compared them with the ECHO, with the hospice, with the nursing homes who didn't attend the ECHO sessions. Well, actually, we didn't. We had just a pre and a post. Sorry for this. We had a pre and a post. So we've pre-echo 8, post-echo 8. They're slightly older post-echo. That's just an anomaly of the data collection. This was also published in Age and Aging abstract in 2019, and it's with Age and Aging now for the paper with the reviewers. So when we look at the phases score pre-echo and post-echo, there was a reduction in the phases score, which tends to suggest maybe improved care, but I suppose the reality is, firstly, it was only a trend, and secondly, phases score is not a kind of an ordinal scale where higher figures indicate greater severity. So instead, we looked at those who had a phase score of 1, indicating that they were stable. And in the pre and post-echo, we found that 6% pre-echo had a phase score of 1, whereas 26% in the post-echo period in the nursing homes that were participating in the echo had a phase score of 1. So more likely to be stable post-echo than pre-echo. Also, we looked at pain score, which is a reasonable ordinal score that reflects severity in a kind of a linear fashion. And we did find also that there was a strong trend towards reduced pain in those post-echo versus pre-echo. Now, when we controlled for age, the statistical significance dropped out, but we were dealing with smaller data sets, so multivariate regression with smaller data sets is challenging. So phase 1 showed that among 22 participating nursing homes, staff confidence was enhanced, and it was so for 6 weeks. And it benefited staff regardless of years' experience or staff role. In phase 2, we found we didn't have an effect on hospital transfers, but they were more likely to have discussions around what they'd like. And in the nursing home in general, there was an increase in not for resuscitation status. And then when we looked at the community palliative care input in nursing homes around St. Francis Hospice, we found that there was a trend towards reduction in pain scores, but also maybe more referrals. So they were more aware of the impact of palliative care.